And welcome to this webinar on patient safety and quality monitoring, focusing specifically on the ventilated patient. With us today, we have Mr. Josh Rains, Manager of Patient Safety at Integris Health. Josh, welcome and thank you. And the floor is yours.
All right, thank you, Maya. Thank you for everyone who attended this or joining in on this. I'm really excited to share all the things I've learned over the years in the hospital, especially from a patient safety perspective. Before I do that though, let's get into our objectives. So, excuse me. I hope to share this information with you, and I hope that it helps you identify and understand the role of patient safety and quality management and what those teams play in hospitals. And we're working on improving patient outcomes, identify key ventilator settings, which are important to monitor in mechanically ventilated patients, and then learn about potential solutions to remotely monitor those patients and to give them greater outcomes. Before we get into all that though, I'll tell you a little bit about myself. I started in respiratory in 2002. I was working at a level 1 trauma center. As you can imagine, a place like that, there's quite a diverse patient population. And so I learned a tremendous amount, patient care, ventilator management, those kind of things, working at that facility. Very grateful for the time that I spent there. From there, I moved on to a cardiac hospital, excuse me. There we were almost 100% RT protocol driven. So we had a ton of autonomy. We watched, the big thing that we were working on was extubating cardiothoracic surgery patients in a timely manner. That was one of our big metrics. I ended up becoming the manager of one of the campuses in the RT department, and that was one of the big things that we tracked, was how fast we could get patients off the ventilators. We had big scorecards on the board, and we were updating it in real time to make sure that we were staying right on top of getting those patients extubated. We actually did a really good job of aggressively weaning in a safe manner. From there, I moved to Integris a few years ago, where I became the director of the respiratory department. This campus, and then like a satellite campus about a couple blocks away. Excuse me. The Integris system is comprised of 7 total hospitals all over Oklahoma. So it's a pretty big system. The department where I worked, where I was the director, it was the largest. We had about between 130 and 140 RTs. And there's almost 500 beds in the main campus and not quite 100 in the second campus. So that having, what I learned from being the director at the RT department was I needed to be able to keep an eye on all the ventilators, make sure that vent management was proper across both campuses. There are a total of 8 ICUs, 1 NICU, 1 PICU, of course our ER holds. So that was a lot to juggle. The good thing is I had a terrific team, high quality RTs. They did a great job. They still do a great job. That it was my management team. We would sit down and brainstorm together on how we could better improve patient outcomes, how we could drive down our ventilator length of stay. That was one of the big metrics I monitored. And so I'll share with you some of the things we did, but we really did a lot of good work, got a lot of success in our vent management. So it worked really well. But in February of this year, I switched roles and moved to the patient safety role. I'm the program manager of patient safety for Integris. So I go to all the hospitals, and we just follow up on anything that could potentially be a safety event. And we try to make sure that we have all the proper processes in place and to take better care of our patients. I think that the safety department kind of reached out to me because in addition to being an RT, about halfway through my RT career, I went to law school. I'm still a standing member of the Oklahoma Bar Association. I don't practice much, but I do little odd jobs on the side, maybe friends and family type stuff. But anyway, I think that my boss thought I would be a good fit because I could look at our safety and quality through two lenses as an attorney and as a clinician. I'm not sure she still feels that way, but I'm not going to ask her. I'm just going to let her go. So I want to talk to you about, my computer will work here. Mechanical ventilation. Okay. So this patient population, obviously, they are some of the sickest of the sick, unfortunately. They are probably the highest acuity level patients we have. They are highly susceptible to ventilator-associated events. And I've listed some of those on the slide there. We've got probable associated ventilator pneumonia, acute lung injury, acute respiratory distress syndrome, or ARDS, infection-related ventilator-associated conditions. In addition to that, though, these patients are also at an increased risk of becoming septic, continued or recurrence of respiratory failure. With these patients, or an example of these patients, I think of COPD patients. You know, they're harder to wean off the vent. We get them off the vent, and sometimes, unfortunately, they have to go back on. Delirium from sedation, obviously, they're more susceptible to that, and also they're obviously more susceptible to death. So that being said, mechanical ventilation is necessary in many patients, and when managed properly, it can lead to great outcomes. And the important thing that I think RTs or any caregiver needs to remember is not to become complacent in managing a ventilator. I've worked with, luckily it's only been a few people who it feels like they're just in there to do a vent check and get their paycheck and go home. And that's not providing exceptional care for our patients. That's not what we should do. We should always strive to continue improving, and we should always strive to provide excellent health care. So I think it's important for RTs and nursing and physicians and anyone involved in a patient's care to, when you go into that room, try to track trends throughout your shift. Notice, you know, when you're doing your vent check or you're doing your assessment, if something's different than it was before, it's important to make note of that. And it's also important to escalate that during rounding. And that early intervention is key when it comes to healthcare, and it's especially true with mechanically ventilated patients. And excuse me, the thing I think is important, and I try to tell people when I had new orientees in training, is that you need to remember what you're going in there to do. You're going in there to take care of someone who basically is depending on you to keep them alive. And I know that sounds a little dramatic, but early intervention, tracking trends, making sure that you're paying attention to what you're doing instead of just clicking a button or writing down numbers is important to get to that level of exceptional healthcare. Let me see if I can get this slide to change. Okay, so excuse me. Let's talk about patient safety and quality. I really didn't know much about safety and quality before I got my current role, but safety and quality metrics are actually some of the most important things you can track in regards to healthcare. So what does that look like from a mechanical ventilator perspective? If anybody watching this today has ever been in RT leadership, you know these metrics. Those are things that we usually have to report out on. So alarm compliance is pretty straightforward. It is directly tied to patient safety and patient quality. It's also pivotal in lung protective strategies. The tighter the parameters in which that ventilator is set, the alarms are set, the more protective we can be of the lungs. It's really straightforward. So the early extubation point, that actually has several little metrics that can go under it. Some of the things I track would be vent length of stay, which gives you an idea of how, like an average, the way we did it was an average of how long a patient was on a vent. Then you looked at, we also looked at vent days. I think probably every RT department tracks vent days. It just gives you an idea of the volume of ventilation. We also looked at, some people look at, there's a great debate over reintubation rates. I think that I tracked them internally. I didn't report those up. Some of the physicians don't want to see reintubation rates. I tracked them just to see if there were any trends, any changes. And if I saw them go up or go down, then I started asking why and looking into it. But a couple of sides to the debate. As a side note, some people say you can't establish a good baseline. You can look it up. Some people say 5 to 10 a month is a decent baseline. Then some people argue that it depends on the patient population as to how fast you get them extubated or how, or if they have to be on the vent longer. The other side is you track that because you need a certain amount of reintubation rates just to show that you're aggressive in your weaning and that you're kind of pushing the envelope on weaning. And so I'm not here to debate that point, but I did track it just to see. I tried to get as much data as I could, and if something was changing, then I would ask why and try to look into it. Oral care, that's really straightforward. It's directly related to VAP and ulcers in the mouth, things like that. The mode and parameter appropriateness, these are things, I know that RT directors do this. You want to look for alarm compliance. So that's kind of mode and parameter. One thing that we did that we always tracked, or we like to keep track of, was the order needs to match what the vent's set at. If it doesn't, then we've got a problem. We're not following the orders. But I always wanted everyone to go further than that. It's not just about what's ordered. We need to make sure that's appropriate for the patient. So the goal, anytime you intubate someone, the first thing you're supposed to think about is how do we extubate them? And so I encourage all my staff to ask questions professionally, politely, but always be inquisitive and always try to understand why we're doing something and making sure that that's the right thing for the patient. This is obviously not an all-inclusive list. These are just some of the things that patient safety and quality metrics play into mechanical ventilation. So, excuse me, a lot of governing entities like Medicare and Medicaid will require certain metrics to be reported up. It's mandatory, things like specific mortality. And most hospitals, I'm sure all hospitals, have metrics they track. And this goes way beyond mechanical ventilation. If you look at anything from visitor falls, track how many visitor falls and severity, or dietary might track timeliness of getting food trays to patients, or if it's the correct food tray, if they have a specific diet and it's not followed. So each department has its own set of metrics throughout all the hospital, and that's how you measure that department's performance. It's real straightforward. But the idea is, as the department leader, you have to monitor for these metrics. You have to track them. You have to make adjustments when you're not hitting your goal. So that's 100% the exact same for mechanical ventilation specifically. I mean, there's plenty of RT metrics that we monitor, but ventilation metrics are kind of our bread and butter. It's kind of our wheelhouse. But in this whole continuing improvement process, you always look at ways to make it better. How can we, all right, this was our goal this time, we need to make it better. We should always push ourselves to continue to improve. Okay, I've got a quick polling question. So, patient diagnosed with COVID-19 who was intubated and placed on mechanical ventilation 3 days ago. His initial ventilator settings are tidal volume of 550, rate of 22, PEEP of 5, 100%. He was weaned to 40% a couple hours after intubation. However, yesterday his FiO2 was increased to 70% and his PEEP was increased to 10. And he's got a worsening chest X-ray. So I'm going to give you guys about 30, 40 seconds here. You can interact, answer on your screen, but do you think this patient would benefit from increased monitoring? Okay. Well, thank you guys for participating in that. Overwhelmingly, we had yes votes. I know that that's an oversimplistic example, but I think this patient would benefit from increased monitoring. I certainly don't think it would hurt. But my goal in asking this question was to kind of get you in the mindset of thinking about catching trends early. If you see something happening, then report it up in rounds, get it addressed. Maybe you can intervene, maybe you can keep it from being a serious safety event or ventilator associated event. Excuse me. So in this example, if we were doing our rounding and we were able to track trends, or if you're cognizant enough to notice what's going on, it jump from 40 to 70% and up in the peeps, pretty big jump. And that's going to be something that's probably going to be noticed. But if it was something which was more subtle and you could still track it and catch it, and you report it up in rounding, there's a good chance you could intervene. Maybe you could change the outcome and provide exceptional health care. So speaking of exceptional health care, I shamelessly borrowed this from one of our physicians. She's a wonderful physician with us. And we were in a meeting one day, and she was quite passionate about providing exceptional healthcare and what that looked like. I wrote the definition that I put up there, but this is kind of the way I see it. I see that patients deserve top quality healthcare and environment free of harm. Obviously, we're not in this to hurt people. We're in this to help people, but unfortunately it happens sometimes. But I think that they deserve the best quality we can give and in a safe manner. And so those two elements will be quality and safety. And that's where I've landed in my career. But we'll talk about safety first. So the World Health Organization defines safety as the prevention of errors and adverse effects to patients associated with healthcare. So this definition has two prongs to it, two elements to it. That's going to be, get this slide to change. This is going to be the prevention of errors. It's also going to be the prevention of adverse effects. So for the prevention of errors, we're talking about close monitoring or surveillance. One of the big things for me is verifying ventilator settings. I think that's important. If we have a pulmonologist come in and make changes to the ventilator, we need to make sure that they know how they want it set up, and we have the ability to verify, and we can offer suggestions if we have a different idea. A lot of pulmonologists are receptive to RTs suggesting trying something different, but the important thing is it needs to be ordered, and it needs to be ordered by the physician. So I was always a stickler for making sure our event orders matched our settings. It's just too easy. It's too easy to do, and it's too easy for it lead to mistake. And so if we verify that right off the bat, we know that we have exactly what is ordered by the care team. Then that kind of brings me up to the second point under prevention of errors, and that's communication across all disciplines. I am a firm believer of communication. So if you know my wife, you could ask her and she would probably verify that I probably am a little too passionate about communication, but it's really important in the healthcare setting. It's really, really important to mechanical ventilated patients. If everyone's on the same page, then everything works better, it flows better. And a good example of this is if you have a nurse and an RT and they're going to do an early morning SBT, spontaneous breathing trial. If the sedation's not lifted, you're not going to get good results on your SBT. Again, it's a simplistic example, but it just is a good way of illustrating that we need to be able to communicate. And the opposite's that true. If you go in and nursing thinks that the patient isn't hemodynamically stable, both sides need to be able to talk about that together, work as a team, and be like, okay, we need to hold the SBT for this morning because it's not safe for the patient. So it is, that's a really important element of patient safety, certainly of quality as well, but we'll get to quality in a minute. So The last one that I have under prevention of errors is often overlooked, and it is underutilized, but that's reporting near miss events. And unfortunately, you all will hear me say this a few times during this webinar, but not reporting near miss events is it's not good. It's not. It doesn't lead to exceptional health care. It can, if it didn't reach the patient this time, it doesn't mean it won't reach the patient next time. So report when something almost happens, even if it doesn't reach the patient. Maybe you could intervene, or a process could be implemented to prevent it from actually getting to somebody else. So you'll hear that several times during this talk. So what about the prevention of adverse effects? That's a lot of that has to do with appropriate ventilator management. Excuse me, in my opinion. I've mentioned it before, but making sure how the ventilator is set up it's pivotal. It's a great way to prevent adverse effects from happening. So when you check things like make sure the tidal volume is correct for the patient, make sure if they're on pressure control, that the instrument pressure is correct, that you're getting good return volumes. You need to frequently check things, make sure your PIPs are under control, that your plateaus aren't climbing up, that just the more that you can make sure, the more you can check to make sure that the ventilator is functioning appropriately, I guess is the best way to say it, for the patient, the better care you're going to give to the patient. And so, and that will help you prevent adverse effects. So it's not only, I have it's an interesting perspective now from where I'm at and from where I've been in the RT department, but it's important to check those every time you go in the room, or, within reason, check all the stuff you can when you go in the room. But it's also important to be able to go back and look at those retrospectively, because if you do have an event reach a patient, or you do have an event with a ventilator, it's good to go back and take a look at how it was set up, how it was working, all the readings, and retrospectively, so you can make sure that there wasn't something you could have done differently, or something someone could have done differently. And so it's nice to be able to do that for auditing purposes, I guess is the best way to say it. The other two things I have up there, optimal PEEP, obviously it's kind of a no-brainer. You don't need to have excessive PEEP, more than what's needed. You don't need to have subtherapeutic PEEP. You need to have therapeutic PEEP. So it needs to be right where it's most beneficial for the patient. I feel like I'm back in RT school saying that, but we all know the adverse effects which can come from too much PEEP. And so we just need to make sure it's just the minimum effective amount of PEEP for the patient. Alarm compliance, you're going to hear that a lot from me too today. I'm big on alarm compliance. I think that it's a tough metric to stay on top of and to keep in check, but it's an important one. I don't really need to explain it, but you can't just go in there and turn the alarms off, or you can't set them so high or so low that they don't actually alarm when something's going on. It needs to be relevant to the condition. When it goes off, we need to address why it went off and fix that problem, instead of going back and just making it quiet. And that's it's kind of a big pet peeve of mine, because I don't think that does not lead to exceptional healthcare. So this is safety. Let's talk about quality. The federal agency for healthcare research and quality defines quality as doing the right thing at the right time for the right person and have the best possible result. So this is, I could break this down into 3 different elements, but it would be redundant. I'll explain that in just a second. So the right thing at the right time for the right person. If you break all these down into, or if you break that definition down into 3 different elements, use an SBT, for example. If you did an SBT on the wrong patient, you wouldn't be giving quality health care. And so you could say, if you weren't doing the SBT at the right time, you aren't giving good quality health care. So all of these, you can't really break this definition apart, because it would just be redundant, and they all fit together. But I've listed a few up here. Obviously, this is not an all-inclusive list. Frequent SBTs for patients who qualify. This directly relates to driving down the ventilator length of stay for patients. You can get them off the vent faster if you're constantly checking to see the optimal time to take them off the vent. That was a big metric that we tracked in our department. We did a really good job with it. I'm very proud of my team, how well they did with doing, we did twice daily SBTs. They still do, but I think that's a growing trend, a lot more frequent SBTs when it's appropriate for the patient. Limiting sedation for patients is really doing the right thing. It needs to be therapeutic, obviously, but we also need to have sedation vacations. We don't need to just be knocking people out for a couple of days and waking them up and hoping that they are going to be able to extubate. Of course, some patients may need heavy sedation, quite a bit of sedation for a prolonged period of time to resolve their pathology, but when it's appropriate, we need to have good sedation management, I guess is a good way of saying it. I've covered it on the next one a few times, but it is relevant for quality just as it is for safety, because setting the alarms is doing the right thing. So I went ahead and threw it up there anyway. And then the other thing I've harped on already, but verifying orders and ventilator settings, doing the right thing for the right patient. Extubating as soon as feasible. That one goes right to doing the right thing at the right time. I kind of used it as an example at the beginning of the slide, but it's certainly within the scope of quality when we're talking about mechanical ventilation. So now let's talk about optimizing the process. So what kind of things do you think about in order to optimize the process? And how do we get that optimization to the point where we're delivering excellent healthcare? Obviously, again, this is not an all-encompassing list, but some things to consider are monitoring, tracking, reporting near-miss events. So monitoring, this means checking all the items I mentioned before, all the vent parameters, all the alarm settings, all the things I've already harped on for appropriateness. And we should do that each time we have a ventilator up. We should actually do most of that each time we go in the room to make sure there haven't been any changes, to make sure there hasn't, if we had to go up on something, if our peak pressures are a little higher than they were before, we should, I think we kind of do it inherently. I think it needs to be on the forefront of your mind. It needs to be escalated in rounding, it needs to be escalated in report. It needs potentially escalated to a supervisor or leadership if it's more of an urgent need. But it's something we should be doing all the time, more monitoring. And tracking, this is more looking retrospectively at trends, data, tracking VAEs if you have any. The idea by tracking VAEs and historical data would be, okay, well, what happened here? How can we fix it? Or this happened last month. We need to do better this month. It's a lagging metric. I'll get to that in a minute, but it's something that's important to make sure that your process is optimized going forward. And then here it is again, reporting near-miss events. And it's just for what I said earlier. If it just because it didn't reach the patient this time doesn't mean it won't next time. So if you want to optimize your process, put in a process which will prevent it from happening at all, like a fail-safe. So optimizing the process, we're looking at monitoring, tracking, and near-miss events. It's really what I'm going to talk about. But how do we do that in the scope of mechanically ventilated patients? Well, for monitoring, it has to go beyond the minimum standard. So a good example, it's a clear example. I don't know if it's the best example, but I put up here that hospitals have policies in place regarding ventilator management, obviously. One of the ones that are up there are how frequently you check a ventilator. When you check at Q2, check at Q4. If you have someone who, like I described earlier, who wants to come in and just do a vent check and go home, and your vent checks are every 2 hours, they're going to check on that patient 6 times before they leave. that's not monitoring frequently. That's not an optimized process. So the thing with doing the minimum and doing only what the policy says, I have issue about that. I think I mentioned it earlier, but a good example, a good analogy, say in products liability law, it's well established that if you just meet the regulatory standards, that doesn't mean a manufacturer couldn't be negligent. And so if you spin that around to healthcare, the logic is still the same. We don't manufacture anything, but if we only do the bare minimum that's required of us, that doesn't mean that, it certainly means we're not doing our best, but we could potentially miss something. And that's, it's not optimizing our practices. So there are several ways to increase monitoring of patients who are on the ventilator. So it can lead to, the reason to monitor more is it can lead to discovering things earlier and earlier interventions. So there are several ways to increase monitoring patients for RTs and well, for any caregiver. I know that there are a few companies that have technology out there now for remote monitoring. I've seen something from GE. I've seen something from Medtronic. I've never used them. I just saw them online with a Google search. I don't know anything about them. I have used Respiratory Knowledge Portal from Fire. We currently have that system set up with Integris. And you can virtually monitor, we can monitor someone virtually from anywhere as long as you have an internet connection and you're following your company guidelines. I mean, I want you using Starbucks Wi-Fi to check, but it's fascinating software, and you can keep an eye on those patients in almost real time, and you can go back and look at anything, even after they're discharged, that happened with the ventilator, any changes that were made, any alarms that went off. It's fascinating what you can check. They also have, and again, I don't know about the other companies. We've tried this. They have a new app that's out called Messenger, and it's just an app that goes on a smartphone, and it will alert you in near real time if there is an issue with the ventilator. It's completely configurable, so you don't have to worry about alarm fatigue. But if there's something that you are concerned about, or if something that you want to be notified about happens, it will notify you. This, like I said, we trialed it and we loved it. It was great. But the real good, the big advantage to the Messenger app, I think, is those assignments. Some RTs have a split unit, so they have a few unit patients, and then they have patients in IMC or on the floor or something, and they can't be in the unit 100% of the time. And of course, there are times that you just have to step off the unit. This is good. This is a good tool to have because it won't overburden the primary therapist in the unit with 8 ventilators. It will allow you to keep tabs on it in real time, keep monitoring it in real time. The other advantage I found, or at least I think it is, you could use it with your supervisors. And so it depends on the size of your hospital and how many ventilators you run. There were times that our department would run 50 to 60 ventilators a day. And so that'd be hard for one supervisor to keep up with 50 or 60 ventilators if they're alarming and alerting the phone all the time. So within reason, I think it's really good it's a good app for supervisors. And I'll tell you a little bit about how we used just this software in our rounding, and I think it made a big difference. And I'll also tell you about a study that we've got. It's on this in the slide deck. But using this kind of software really improves patient safety and quality, and it certainly can help increase your monitoring. So that was monitoring. Let's go to tracking. So the topic is optimizing a process. So when I'm talking about tracking and trending, they're obviously lagging metrics. It's still very useful because even lagging metrics can drive process improvement. Here are some of the things that I would track with the RT department. The 2 RT departments I've been manager of. So watching for ventilator-associated events, important things you need to keep in mind: PEEP, pressures, FiO2, underlying pathology, sedation. So with the, I don't know about other manufacturers, as I said, but with the knowledge portal that we used, they have a screen called surveillance. And so on the surveillance screen, you can, it was broken up in 3 sections. On the left, I just called it the green zone. It's not the official word, but that's the way I put it in my head. It's the green zone. That's just all the patients being monitored. The middle was what I called the yellow zone. And so if there was a significant increase in PEEP or a significant increase in FiO2, they went from the green zone to the yellow zone, or to the left to the center column in the screen. And so when I'd see those, that's warning you that there's been a significant change in the settings on the ventilator. And so that's when you start looking in. So you can go in and you look at the underlying pathology. Is it worsening? Is it resolving? Is it something that we can intervene with? You can look at if you're tracking like missed SBTs, the software will tell you this patient missed an SBT this morning. You can go in and look, was the sedation turned off? The software will even track sedation. If you have pumps that are programmed in and communicating with the system, it'll tell you what changes were made on the pump, and so you can see if your sedation was lifted or not. A lot of times that's the cause, and the patient could have been extubated. Sometimes it's not, but it's good to track it so that you at least eliminate it as a possibility. So so back to the surveillance screen. They stay a significant increase in PEEP or FiO2 stay in the center. If it's 48 hours, they get switched over to the right side of the screen, or the red zone is what I call it. So in the red zone, it is considered a ventilator-associated event. And so that triggers you to go in and start investigating as to why the change was made, and to see if it could be prevented. The whole reason we track them. But the idea, I think the idea here, though, would be to have all your caregivers have access, be able to look at this in real time. It's probably something they should talk about in their report to each other. Hey, I checked knowledge portal, everything's fine. Or, we've been trending up for the last 2 days, but it's also important to report this up in rounding. Hey, we've had to go up, even if it's by a little bit. Hey, we had to go up, or we've been staying here for 24 hours. We've been at this for 24 hours, this setting for 24 hours. We need to figure out how we can get that done. I think that really would drive better patient outcomes and improve patient quality and safety. So let's go to my big one that I've been talking about, reporting near-miss events. So I know that I've harped on this quite a bit, but report. All events, anything that happens. Doesn't matter if it reached your patient or not. If it was close, if it could have been potentially harmful, then I think it's worth reporting. And I know that we encourage people to put in an actual incident report under the category of near miss. And we like to give kudos whenever someone reports a near miss or has a good catch. We like to reward that and recognize that person for doing a good job and reporting it up. So with the software that we had, I would the reports are phenomenal. Just about anything you want to see, they're on there. So it could give me all the things I mentioned earlier, like length of stay, vent days, reintubation rates, associated vent costs. It could give you ICU length of stay. It's phenomenal. I've never seen a spreadsheet go across 2 computer monitors, but there's a lot of information that you can gather out of using that software and checking on those patients. And I could spend the rest of the hour talking about all the stuff on the report, but I won't. But there's a lot more to track. There's just a few things that I tracked, I put up there. But we're talking about near miss and optimizing the process. So the importance of reporting the near miss events. will tell us what we need to do in the future. And using this software, it's really convenient to go back and look at those near miss events. I'm hoping I'm painting a clear enough picture here, because if you have somebody reports a near miss, you can jump in the software, you can look at the ventilator, see what happened, and then go, oh, we shouldn't have this process in place like this, or, oh, we need to change this part of the process so that it doesn't even get that close to the patient next time. And so that reporting near miss is important in every aspect of the hospital, but I'm just trying to make it relevant to, or how it's relevant with mechanical ventilation. So it's really important because you can really harm a patient with a ventilator. I think we all know that. And so this kind of encouraging this kind of culture and reporting it, and you having the technology, the ability to go in and look at it in that grade of detail, really helps analyze the process and ultimately improve it for better patient outcomes. So frequent monitoring is critical. I know it's kind of an obvious statement, but RTs who can't be on the unit all the time, if they have that split assignment I was talking about, they can still keep an eye on their patients frequently without having to be right there at the bedside. I'm not advocating that we don't stay in the unit. I'm not advocating that we don't keep a close eye on our patients. These are just tools that will help do that, and be mobile if you need to be, because a lot of times we have to be mobile. So one of the things that I did with regard to frequent monitoring was when I was in the RT department, I had a big TV put on the wall. It was like a 60-inch flat screen. I had IT connect a computer to it, and we could have respiratory knowledge portal on a continuous loop in the RT department. And our department was considered a closed unit, so we didn't have HIPAA concerns, but it was really great because you could have it in a loop, and it would show things. It would show things like SBTs that were not performed, missed SBTs, and it would tell you which patient, what time the SBT was missed. We had set times at day and night that we would do SBTs, and so it would flag if it wasn't done within that time period. Then it would tell you what patients were on higher concentrations of oxygen. They come up in little boxes, little pictures, and it would be yellow or it would be red, depending on how much oxygen they're on. They would tell you things such as alarms not in compliance, just really just tracking all these metrics. And you could set the loop to go through as fast as you wanted it to, and it would scroll the whole time. I did have an issue with the screen timing out, but it wasn't software. It was our IT department. So they have strict policies on making your computer lock after so long. But my goal was to increase staff awareness of our ventilator patients. And I wanted a second one in our department in our break room, because I left the department before I got it done, but I would love to have had it be a conversation piece in the department break room. If somebody's down there eating lunch, they could lean over to their buddy and say, why didn't you do an SBT on Mr. Jones this morning? So that was kind of my goal, my vision. And if anybody is interested in something like that, I'd encourage you to do it. It's a really good way to make sure everyone's aware of what's going on. We did that when I worked at the cardiac hospital, was the manager in the RT department. We used the giant sticky notes and put them on the wall, and we put what time the reversal was given, what time we wanted it done in 4 hours, and so we'd put what time the patient came out, what time the reversal was given, and what time we went to switch to mode 2 or weaning mode. So it was, and it was almost like a competition because they had so many thoracic patients that we would extubate in a day. We would just put them up there, and now my slide deck's going out of control. So we would just stick it up there and just have a little friendly competition in the department. So, but before I go to the next polling question, I want to tell you how we utilize this most, and I think it's most important in terms of patient quality and safety. Our supervisors had tablets they could take with them and round. I asked them to do an SBT report for me every shift. And so they would go and check on every ventilator, every shift, and talk to the RT who had it. I just wanted to know if a SPT was done, if not, why, and if the ventilator orders matched what was on the ventilator. And so this just brought awareness to everyone that, hey, we need to push and extubate these people. And I really wanted it. I thought it would, two minds are better than one, obviously. And I thought it'd be great for the supervisor and the RT to have the discussion about the patient. And so what we would do is look it up. You could pull up the patient and say, look, I see this is going on. I see this has been going on. How's the patient? What's going on with the patient? How can we fix it? And I really want this escalated at interdisciplinary rounds too, so everyone can intervene. But it really drove down our vent days. I had my metrics set at a certain level. I actually had administration come and inspect my metrics, and one of the administrators thought I should increase my vent length of stay because it was he thought it was unobtainable. And then it was about 2 months later, we were consistently under that threshold, and that of course was before COVID. That threw everything out the window. But I think the process was solid. I thought it was really good. Okay, let's get to this polling question. I know that we're running short on time now, but what ventilator alarms would you want to know about if you couldn't be in the room at the time the alarm went off? All right. So if you guys can't tell, I made these questions kind of simple, but I appreciate you taking part in that. I would say all of the above too. You could get alarm fatigue, but those are all really important alarms. And so I think it would be important as well to know about them. But I'm just trying to illustrate how remote patient monitoring could be useful, could be an effective tool. If you were off the unit and you had a low inlet O2 alarm going off, that you better get there right away. And it's the same with any of those. Now the high PIPs, of course, you could have a patient cough and make that go off, but you got to go check. So this is really even helping with help. Wow, I need to use my words. This could really be useful given our recent pandemic, and the RT staffing was spread thin everywhere. And so, again, not advocating for not being at the bedside, but this could tell you who it used to give you a triage if you needed to. If you say, I can finish the other vent checks in a minute, I got to go check on this one, it's emergency. So thanks again for participating in that. So here's a study. It just came out, I think, a couple of weeks ago. And I've got the citation on the last slide. I'll make sure I get there. So it was a retrospective observational study performed on 337 patients in a large hospital in Georgia. The control group was 187 patients. The ventilator data was reviewed from the respiratory knowledge portal, and it was routed to ICU workstations, but the intervention group was 150 patients, and their data was ported to tablets for use during interdisciplinary rounds, kind of what I was mentioning earlier. And the results were the control group had VAE reported 11.2% of the patients. Intervention group reported VAEs in 2% of the patients. So we've got a little over 9% reduction in VAEs just from talking about ventilator trending and data in interdisciplinary rounds. It's what I've been talking about the whole time: more monitoring, early intervention, and it's a retrospective analysis of how it works. So now I'm going to talk to you a little bit about Knowledge Portal, and mainly because I know the most about this over the other things. But and I said it before: closer monitoring, early interventions. That's what this is all about. I don't really need to cover what you can track or monitor in near real time. I just threw a few of the things up there. There's things I'd like to watch: alarm compliance, sedation vacation, SVTs, ventilator-associated condition trends, data reporting. It's great for reporting to your physician groups, your med quality, those kind of groups. Renovations, again, we don't have to get into that, but ventilator-associated costs. Now, I can tell you that's a really good one because it's how much you're saving the patient and how much you're saving the hospital. But the faster you can effectively wean a patient, the better it is for them physically, and it's better for them and the hospital financially. So it's really game-changing to be able to have something like that on hand, and it's really great. CFOs love it. They love for you to sit down and show them how much money you can save by doing exceptional healthcare. I know I talked about the messenger app. I just want to talk about it just a little bit more. It's great, again, for RTs who have to be off the unit. It's great for lead staff who have to bounce around. It was great for us. Well, we didn't use the messenger app for the weaning, but it was a similar version. We just went around with the tablet, but the messenger app will actually give you alerts. So that's helpful. It tells you where you need to be. It kind of helps you triage if something's going on. And I mentioned it before, it's configurable. So you get to set what alerts you want. And then it really helps give the staff more mobility, and it increases their responsiveness. You don't have to worry about waiting for somebody to call you. And then, I'm sure it's happened to a lot of people. Sometimes the person call you can't explain to you what the problem is. They just tell you to get there. And so this, you already know. It's great. So I got one more polling question. We're almost done, and we'll open it up for questions. So when conducting retrospective analysis of ventilator data, which one of these is the most important? Cost savings, ventilator length of stay, vent days, reintubation rates. I like this. I like the diversity in this one. It's good. Okay. So ventilator length of stay wins it. I intentionally left this one without an all-encompassing option, all the above. And it's because I'm going to give you a famous attorney answer. It depends. Different individual looks at different things. They want different metrics rolled up to them. So I've had physicians who do not want ventilator length of stay. They only want vent days. I've had others who want vent days, reintubation rates. And then of course, CFOs, they really want to hear about the cost savings. And so all of this is really easily accessible, and a lot more when you use things like Respiratory Knowledge Portal. Again, I don't know about other forms of remote patient monitoring, but this one's exceptional, and it's really easy to go in and look in real time, near real time, and then it's easy to go in and look retrospectively as well. That being said, I just want to thank everyone. I want to thank you all for what you do first. I know it's been a rough year for all caregivers, but I am proud to be an RT. I'm proud of everyone out there taking care of patients, especially during this time. So I appreciate all you're doing. And I think we'll open it up for a quick Q&A. I think Maya's going to read them.
Absolutely. Thank you, Josh, for this presentation. So we did have a few questions come in, and I'm going to start with the first one. Okay. Could you please elaborate more on safety protocols for ET intubation till weaning?
And say that last part again. I'm sorry, I didn't quite hear it.
So could you please elaborate more on safety protocol for ET intubation till weaning?
So elaborate more on a safety protocol. And I hope this is responsive to what's being asked. So that the idea is, as soon as we intubate someone, the goal is to extubate them. when it's time. Obviously, you can't just extubate somebody right off the bat. That would be useless. But the idea is to monitor them and track them, and then extubate them when it's safe to do so. What I mean by extubating, you should start thinking about how we're going to extubate them. What do we need to treat to fix the underlying condition? And then we need to start getting them off the ventilator. And so I know that we would try in the appropriate patient, again, that's always the key. We could start trying SBTs as soon as the next day after intubation. And so as far as a safety protocol goes, I think everybody's going to have a different set of parameters and set protocol. But I think the general idea going into making a protocol like that or reviewing a protocol like that is to see how can we safely extubate this patient as fast as possible.
All right, thank you, Josh. Another one came out as well. Could you clarify SBT against spontaneous weaning?
It's saying clarify SBT against spontaneous breathing.
Well, the question says spontaneous weaning.
Oh, spontaneous weaning. Okay. It might be a geographical difference in the way we're talking about it. My assumption is they're the same thing. So spontaneous breathing trial, we go in, we assess the patient, we make sure that they do have spontaneous respirations. We make sure that their RASS score, their sedation score is at an appropriate level. We make sure they can follow commands, make sure they're hemodynamically stable. We make sure that their underlying pathology is resolved or resolving. There's a whole list of parameters we look at to make sure they qualify for an SBT. When we start to actually do the SBT, we put them in a pressure supported mode, and we just observe them to see how they do. We watch all their different breathing mechanics. We watch their vitals. We make sure that we don't leave the bedside for a little bit. We make sure that they're stable. And if they continue to be stable, then we can report that up to the physician. And a lot of times it's time to extubate if they pass their spontaneous breathing trial. There's other things we'll examine before we extubate them, but that's kind of the gateway to get them extubated. So I don't know, some places might just say spontaneous weaning, and that might be what they mean by that, but that's the best way I can define how we lay out spontaneous breathing trials. At least around the Oklahoma City metro area. That's everyone talks of it that way.
Okay, thanks, Josh. Another question came in. Do you include unplanned extubations in your early extubation monitoring?
So in a short answer, yes. If we can go in and take that one out and change the average, but and that's another reason that we try to catch that I would track reintubations too, because if you had an unplanned extubation or a self-extubation and the patient wasn't reintubated, it's not an ideal state. I don't think it's optimizing healthcare. I don't think it is. I don't think it's the safest thing for the patient, obviously, but it's still a successful extubation if the patient wasn't reintubated. So I still think it counts. The big question I have a lot of times is, why didn't we extubate the patient before they extubated themselves if they didn't need to be reintubated? It tells me that there could have been a process in place where we could have, I'm trying to figure out how best to word that, we should have caught it earlier. And obviously they're okay to breathe on their own. And so, but if we report self-extubations. And so if you can compare self-extubations to reintubations, that might explain why you had a higher reintubation rate. So, but yeah, in a short answer, we do include that in our average.
Okay, that's great. Thank you, Josh. We are at the top of the hour, so unfortunately, we're not going to be able to take any more questions. However, thank you everyone for attending. Should you have any additional questions later on, just don't hesitate to reach out, and I'll make sure that I put you in contact with Josh here. You should all receive a survey after this. Once you complete the survey, I will then be able to send you your CRCE certificates, and a replay will be available of this webinar. So make sure you tune in and you keep up to date on when that replay is available. I'll obviously communicate this to you at a later stage. And Josh, again, thank you very much. And I wish everyone a good afternoon or evening, depending on where you are.
All right, thank you.